Hello, my name is Dr. Shanda Blackmon, and I'm a cardiothoracic surgeon. I did my training at Baylor College of Medicine in Houston, Texas, and then I did a fellowship at MD Anderson. And I practiced for the first part of my career in Houston, and they got recruited to go to Mayo Clinic in Rochester, Minnesota, where I was for 10 years. And then I was recruited to come to Baylor College of Medicine, back to the place where I trained, to build a lung institute. My specialty is lung cancer surgery and esophageal cancer surgery, and I focus on caring for patients throughout the whole spectrum of care, from the beginning of their disease to the end of their disease. I'm a professor of thoracic surgery, and I've been practicing for 20 years. So prehabilitation for lung cancer surgery is something that I always emphasize with my patients. When they come to me and they're deconditioned or they're actively smoking, sometimes it is okay to hit the pause button and encourage my patients to take several weeks to try to make sure that they have the best outcome from their surgery. And what that means is, instead of taking them straight for surgery, we take them into a program, whether it's a smoking cessation program to help them to get better from their surgery quicker because they're not actively smoking and withdrawing from tobacco, or maybe it's a recovery program where they go through exercise, or they're given breathing exercises or meditation exercises, or they're given an aggressive regimen to try to get in good enough shape to make the surgery a little more seamless. When people come to us with a diagnosis of lung cancer, sometimes they have something called pulmonary function testing, and that's where they breathe in and out of a tube, and we get a bunch of numbers that tell us the different ways that the lung is working. We look at two specific numbers, one of which is called FEV1, forced expiratory volume, and the other number that we look at is DLCO. And those two numbers tell us whether or not a patient has restrictive or obstructive disease, and whether or not they might be fit for surgery. Some people come and they're so deconditioned that we don't think we can get them through a surgery, and we may refer them for radiation treatment instead of surgery, or chemotherapy with other types of drugs instead of surgery. So most patients want to have surgery if they're a candidate. And in that case, if they're on the borderline, we may take 2 or 3 weeks to put them through what we call prehabilitation, where they work with a coach and they get successive imaging and working with an expert to get stronger, breathing exercises, staying off of cigarettes, using nicotine patches and medication to help them as they wean themselves from cigarette smoking, and make themselves in the very best shape they can be in, so that when they have the lung surgery, they have a better chance of making it through and getting home rapidly. Our goal is always to get patients home right after surgery as soon as it's safe.